as far as the ECMO services are concerned. So I would also like to know about what all the other institutes, how they should follow the protocols and pathways to enhance ECMO services at their centers. And we have Dr. Arpan Chakravarti. Hello, Dr. Arpan. So Dr. Arpan Chakravarti has done tremendous work during this COVID pandemic, and basically he has saved a lot of lives, especially the healthcare workers. Some of the doctors who were admitted in his center were revived, and they are back to their normalcy with the ECMO support services that he has provided. So I think from Dr. Arpan also, I think we will be able to have a understanding of what problems or challenges that he had, and how he could circumvent all these problems and come up with great success. Would like to know from you also, Dr. Arpan. And yeah, and Professor Dr. Nilesh Mahale is a good friend of mine, my colleague from my post-graduation days, and we were the one who did intensive care training together. And then he pursued his clinical excellence and critical care training from Australia, and he has he has fellowship done in ECMO and heart and lung transplants. So from Nilesh, I think he will also be a good addition, and he will also be helpful to give us good insight about how these ECMO fellowships are run, and how can we also start such ECMO fellowships. Professor Diwan is already doing a lot of work on ECMO, but I would like to know from him as well. And he's very keenly involved in eCPR practices. I think he saved a lot of lives in his center. Currently, he's at Dinanath Mangeshkar Hospital, and he has also started with simulation-based programs for training also. So we'd like to know from Dr. Nilesh also, how the fellowships can also be started, and how eCPR can be initiated, because eCPR is still at the phase of dormancy in India. And then I think people like you, like Dr. Nilesh and all, can be a good asset to develop such programs in India as well, with the collaboration from all of you all. Dr. Thomas Muller, I would like to help us with how we can enhance ECMO services in India, and please enlighten us about that as well. And I'm waiting for Dr. Munish Chavan. He's and one more colleague of mine, Dr. Suvadeep Sen. He will also be joining. And my friend Dr. Gunadhar, he has done a diploma in ECMO from La Petit Institute, France. And then he also has been very much instrumental in starting ECMO services at Apollo Hospital. And we have good success stories as far as these ECMOs were instituted for some patients. And we have one more colleague of mine, Dr. Suvadeep Sen. He has also done a diploma in ECMO from same institute where Dr. Gunadhar has been trained. And both these consultants have really added a value as far as ECMO services in Apollo are concerned. So this is in a nutshell about the introduction for all my panelists as well, sir. Yeah.
Dr. Tandekar, a question: how much time do we have all together, and how much time do I have?
So basically, this program is basically intended for 1 hour, but I would like to stretch it for 1.5 hours, because this will be very interesting program, and I don't think within half an hour you will be able to complete entire ECMO basics in half an hour. So I would like to provide you 45 minutes, if it is okay for you. Or you may extend 5-10 minutes more, that is fine. And then we will have good half an hour panel discussion. That will be very, very interesting. And hopefully the students will also ask a lot of questions, and we will be able to make it more interactive and more interesting as well.
Yeah. Have the students a basic understanding of ECMO? What ECMO is? Okay.
Yes, majority of the students are trainee, and it has also been incorporated in the training schedule of their DNB trainee, and majority of the hospitals, they have ECMO right now in India. They have understanding, but still, there would be some chunk of students who would definitely not be well versed with the ECMO, but they definitely have heard of ECMO and they know basics probably. Yes, I feel so.
So just to extend the talk, sir, basically this program also attended by a lot of consultant intensivists across India and those who want to practice ECMO. So with the students, there are a lot of consultant intensivists and practicing anesthesiologist intensivist, cardiac anesthesiologist will be there. So this forum consists of probably the audience who have basic knowledge and interest, and to take the ECMO forward in their institute. So that is the aim, and we do regularly such sessions every week. So this is our 12th of the sessions, and we are looking forward more and more sessions with you and all the eminent panelists here, sir. Thank you, sir.
Great.
And I think we are right in time. 7 o'clock. Sure. I mean, and can we start the discussion on presentation? Sir, can I request you to start sharing your presentation, please?
Yeah, you still give an introduction, but let's see.
Yeah, I mean, just keep sharing it at least, and then I'll quickly introduce everyone, and then within 1 minute, I think we will be able to finish the introduction and we'll be able to start.
Can you see my presentation now?
Yeah.
Can you see my?
No, not at all. No.
You cannot?
No.
Bad.
I think you have a share option.
Yes, and I used it.
Yeah.
Let's try again.
Yeah, it's coming up now.
You see me now?
Yes.
And the presentation is okay?
Oh, yes. Fantastic. I think, yeah.
Good.
Once you start presenting, I think you can go on slide mode so that we will have a entire presentation on the screen as well. And I would like to welcome my friend and my colleague, Dr. Sudip Sen, as I've already discussed about his excellence in the field of critical care and ECMO services. Welcome, Dr. Sudip. Dr. Sudip.
Yes, thank you, Dr. Akhilesh, for your kind.
So with this, hi, good evening, everyone, and my warm welcome to all of you. And today we are here with a beautiful discussion on VV ECMO, VA ECMO, and eCPR by the eminent speaker and the panelist. And the intention here is to provide a good platform as far as the education is concerned. And, we still have a lack of understanding of ECMO, basics of ECMO. So today we are all here to discuss the ECMO, VV, VA, and we will also have a discussion on eCPR. For this session, we have Dr. Professor Thomas Muller, who is the professor and head of the intensive care at Rosenberg University Hospital. And he has been instrumental in pneumology also and ECMO. During COVID times, I think he has an exceptional, extraordinary outcomes with ECMO services. And he has also been working on how to miniaturize the devices as far as ECMO devices are concerned. He and his team is already working on. Today, we will have the opportunity to hear from him the basics of ECMO. Welcome, Dr. Professor Thomas Muller to India.
Welcome. Sure. Thank you.
Yeah, and yeah, we have a panelist and we have my friend. I would like to introduce my friend, Dr. Gunadhar Padi. He is a coordinator and consultant at Apollo Hospital, Navi Mumbai. And he's also trained in ECMO. He's done diploma in ECMO from La Petite Hospital, and he has been instrumental in setting up ECMO services at Apollo Hospital. Of course, the team has definitely contributed. Welcome, Dr. Gunadhar.
Hi, thank you.
Yeah. And I would also like to welcome Dr. Sandeep Diwan. He is the pioneer in India doing ECMO services, and best results have been provided at Fortis Hospital. And Dr. Sandeep has also been instrumental in not only the ECMOs, but I think he has been instrumental in providing scientific content and the programs and the simulation programs, and which are coordinated with ELSO, are being conducted by Dr. Sandeep Diwan, and then majority of the students and the consultants from India have got opportunity to learn from him. So welcome, Dr. Sandeep Diwan. I would also like to welcome Dr. Arpan Chakravarti. He is also a well-known figure in India as far as the ECMO services are concerned, and he has got best results in ECMO during COVID pandemic, and he has saved a lot of doctors' lives, I would say. I mean, who were under his care in ECMO, and they're all back to normalcy. I mean, he has a lot of successful outcomes to really discuss today. This forum. Welcome, Dr. Arpan Chakravarti, to this forum.
Thank you. Thank you.
And I have my friend Dr. Nilesh Mahale, who is consultant critical care specialty at Dinanath Mangeshkar Hospital and trained in ECMO. He has done fellowship in ECMO in Australia. He has not only done fellowship in ECMO, but he has done fellowship in heart and lung transplant also. And currently, he's also doing a lot of sessions on ECMO simulations, and he's currently working on developing eCPR practices in India. So with this platform, the students and all the consultants will also have the opportunity to know from him as well, as far as eCPR scenarios are concerned. Welcome, Dr. Nilesh.
Thanks, Akhilesh.
And we have Dr. Munish Chauhan, also consultant and critical, and he is also very much into the ECMO training programs all over India, and we'd like to hear from him also today. Welcome, Dr. Munish Chauhan.
Thank you, Dr. Krish. Hi, Dr. Muller. How are you?
Yeah.
And I also welcome my friend and my colleague, Dr. Subhadeep Sen, who is also trained in ECMO, did diploma in ECMO from La Petite Institute, and he has been instrumental in setting up ECMO services at Apollo Hospital. Welcome, Dr. Subhadeep.
Thank you.
And
Thank you,
with
Dr.
this brief introduction, I would like to hand over the presentation and the entire program to Dr. Thomas Muller. And sir, I would request you to start the presentation. Thank you very much.
Chandika, thank you very much. I believe you can hear and see me. It's really a pleasure to be at least virtually back to India. I've been 5 times in India and I always enjoyed it tremendously. You see in the background here, Regensburg, which is actually compared to India, a very small city, only 150,000 inhabitants. But Dr. Divan and Dr. Munish know it. They have been here for 2 weeks in wintertime when it was rather cold. Currently, we have almost temperatures like in India. We have around 30 degrees Celsius currently. Regensburg is quite old. As you see in the background, it was founded about 2,000 years ago. But I'm not going to talk about Regensburg today. I'm going to talk about ECMO. And my task actually, I've been appointed to, is to talk about VV ECMO, VA ECMO, and eCPR. What are indications? What is the efficiency? Which news do we have? And I'm afraid you have to stay for several hours now because it will not be possible to cover that in 45 minutes. Still, I will try. Because there's not enough time. We may discuss later on, but I have decided actually currently to skip COVID. So my presentation will not be about COVID-19 and the use of ECMO, but I will talk about ECMO in general. Okay. Good. This is just a few impressions from our ECMO center. Dr. Divan may remember, I think there are 4 pillars an ECMO center actually relies on. One is the patient care, which is central to everything you do. Second, very important part is the teamwork. And you see here our head perfusionist, Alois Philipp, Dr. Dirk Lunz, who is doing a lot of transport. You see our ECMO mobile here in the snow. So these 2 pillars are actually very important for the clinical part, but we also do a lot of education. We regularly do courses for our students, and we also do some science and some research on ECMO devices. I will spend the next 40 minutes with the 3 main topics: VV ECMO, VA ECMO, and eCPR. Can you hear me?
Yes, sir.
Please go on, sir. We will move to the other post.
So you can continue, sir.
You're not audible, sir.
Yes, I was muted too, but now you should hear me again. Is it okay?
Yes.
Okay. So the first part about VV ECMO, yeah, a little bit about cannulation and gas transfer. Which indications do we have? Veno-venous ECMO, okay. Which cannulations we use, which indications do we have, and a little bit about CO2 removal towards the end. Then the second part is about VA ECMO. As you know, VA ECMO is part of ECPR. So which indications do we have? What can we expect concerning outcome? And the third then, ECPR. I cannot talk about problems of ECMO today. This would be a very important topic, but there will not be the time to talk about this. Just in principle for the students, we have in principle two different forms of ECMO. One is VV ECMO, one is VA ECMO. In VV ECMO, this is what we use for pulmonary failure, where we have actually the perfusion taking part from the venous side. We take out the blood, we oxygenate it and return it into the venous vessels. So we have a one vessel system, and always when you have a one vessel system, taking it out from the venous system, returning it to the venous system, there is a risk of recirculation. We will have to talk about this later on. Second part then is about circulatory failure. In VA ECMO, we actually use two vessel systems. We drain the blood from the venous circulation and return the blood to this arterial circulation. So in VA ECMO, in principle, there is never a risk of recirculation. You may not be afraid of recirculation in VA ECMO. Okay, just briefly, a few dashes in here, which I cannot remove, I'm afraid. I want to show you what is the technical ability of our membrane, of our artificial lung we use, how much oxygen and how much CO2 can we transfer with our oxygenator. So I always use, for the beginning of my lectures, I like to use this slide here, which shows you on this side here how much carbon dioxide we can eliminate, and on this part of the slide how much oxygen you can transfer. I just lead you briefly through it. This is a three-dimensional graph where we have on this axis the blood flow. So we increase blood flow from 1 liter to 5 liters, and we increase gas flow on the other side from 1 liter up to 12 liter. And here you see three-dimensionally, and these are actually data points from our database. You see how much CO2 is removed, and you can see with a small blood flow of only 1 liter, but a high gas flow, you can eliminate a lot of CO2. We probably produce around 250 mils per minute, depending whether the patient is septic or not, but around 250 mils. And so you can see already with a small amount of blood flow, you will eliminate a high amount of CO2. That means for CO2 removal, you can actually use smaller devices. When you run on high blood flow and high gas flow, you can virtually eliminate all CO2 production the patient has. So our devices are very effective concerning CO2 transfer. They are a little bit less effective concerning oxygen transfer. You see on a low blood flow here of 1 liter, it doesn't matter whether you increase gas flow or not. You can only transfer a certain amount of oxygen. Again, you probably need 230 to 250 mils per minute. So meaning if you want to transfer oxygen into a patient, you have to run on higher blood flows, which you see here, increasing blood flow and increasing gas flow. You may be able to actually transfer more than 200 milliliters of oxygen per minute into the patient. That means when you have a patient in severe ARDS whom you have to support with your machine, you need rather high blood flows, and means you need rather large ECMO machines. This is shown here. It actually depends how large your oxygenator is. This is a PLS oxygenator with a surface area of 1.8 square meters. This is a smaller oxygenator from LivaNova, which has only 1.2 square meters. And you can clearly see, even on high blood flows, high gas flow, with this one, you will eliminate far more, you will transfer far more oxygen than with this one. Meaning again, if you have a patient in severe ARDS, you have to use a larger membrane. What is interesting when you look into this graphic here, you can see that there seems to be some ceiling towards higher blood flows. You would expect that actually there's a linear increase in oxygen transfer. This does not happen. We seem to have a ceiling effect here on higher blood flows. Why is that? First, when you run on high blood flows, you also have to increase your gas flow because, for example, 1 liter gas flow for 3 or 4 liters blood flow would not be sufficient. So running on higher blood flows always increase your gas flow, and I would say at least 1-to-1 ratio between blood flow and gas flow. What could be possible causes for this ceiling effect towards higher blood flows? Well, one probably is recirculation. That means that you actually use blood again, pump blood again into your oxygenator, which has been oxygenated already. A second may be that the blood oxygen contact time actually decreases. The faster you run your ECMO, the faster the blood will go through the oxygenator. And that may mean in consequence, when you use very high blood flows, you probably have more recirculation, you have a lower blood oxygen contact time, which means that actually our machines are limited to a certain extent. This is how we cannulate here in Regensburg. You see, we generally use 2 cannulas with a distance of between 15 and 20 centimeters to avoid recirculation. I show you in a second why that is important. And this is done in almost 70% of our patients. Yeah, we use the conventional 2 cannulas, drainage cannula in the inferior caval vein, below the diaphragm, the return cannula coming into the jugular vein, and you need at least, as I said, 15 centimeters distance between the 2 cannulas. In Regensburg, we never do it vice versa. However, for example, in Stockholm, they do, and I show you the difference between these 2 cannulations in a second. We sometimes use fem-fem cannulation in our patients only in 2%, but I do know centers who use a lot of fem-fem cannulation. It's easy to cannulate the 2 groins. If you do that, you have to use a large, shorter for drainage and a long one, which goes into the right atrium for return. We use in about 16% of our patients double lumen cannula, only in selected indications. The cannulation is more difficult, the cannula is more expensive, and there can be lots of complications. So Avalon cannulas, double lumen cannulas, we only use, for example, if we want to mobilize our patients waiting for lung transplantation. And in very selected instances, we use this double lumen cannula, which can be used either via the internal jugular or via the femoral vein, which is a double lumen. But this is suitable only for CO2 elimination because it has a lot of recirculation. I told you before that I want to talk about cannulation mode and recirculation briefly to explain to you why management of VA ECMO, proper management, is so important. So we actually did a prospective study comparing the mode we drain our patients, draining from the femoral and return to the jugular, with what is done in Stockholm. They drain from the jugular and return into the femoral. And what we could clearly show, the green line here is the optimal line where you have no recirculation. Down here you have the ECMO blood flow. Here you have the effective ECMO blood flow. If you have no recirculation, this is a straight line going up, and ECMO blood flow and effective ECMO blood flow should be the same. The more recirculation you have, the less effective ECMO blood flow you will have. And if you compare here in blue, this is femoral-jugular cannulation, versus in red, the jugulo-femoral cannulation, you can see a clear difference between these 2 ways to cannulate somebody. So there is a significant higher amount of recirculation in the jugulo-femoral cannulation mode, especially when you go towards higher blood flows. Okay. What is our daily practice? Here in Regensburg, always, and I believe you all do it around the world, always we do implantation with ultrasound control of the vessels beforehand. We do it in Seldinger technique. When we have our guide wires in, when we have done the dilatation, Then we give a bolus of heparin. Why that? Because actually the blood rather fast clots in these large cannulas. While we did in the past give 5,000 units of heparin as a routine bolus, we don't do anymore. There are patients we don't give heparin at all, for example, in trauma patients or post-resuscitation. But as a rule, we would give between 1,000 and 5,000 units of heparin after dilatation, depending on the patient. We drain, as I said, right femoral vein, 21 to 23 French, 38 centimeters long, and we return with a smaller cannula between 15 and 19 French, 23 centimeters long, to the right internal jugular. As I told you, alternative, as you see in this patient, would be a double lumen cannula. We start our blood flow at 2 liters per minute and increase then up to 5 liters per minute. Some centers increase even more. We in Regensburg, we don't. According to oxygenation, that means the more oxygen you have to transfer, the more blood flow you need. And gas flow, we actually start also with 2 liters per minute and then adapt according to pH and PaCO2. I would say around the world, the most common anticoagulation is heparin, intravenously with an APTT of about 1.5 of normal. We are here in Regensburg since September 2017. Use argatroban has a few minor advantages, but overall there's not much difference. We can or might discuss later on why we use argatroban in VV ECMO. Important, adapt your ventilation as soon as your ECMO runs. So before you have a blood gas, decrease your minute ventilation down to 50%. Why is that important? Because there is a high risk for hypocapnia in these patients. You may have a severely acidotic patient. Before you start ECMO, you start your ECMO and your CO2 may come rapidly down from, let's say, 100 millimeters of mercury to 35 millimeters of mercury. And this actually is known by now that it's very bad for the patient. We always do a chest X-ray afterwards. So what is accepted indications for VV ECMO? And this is actually the indication which was used in the earlier trial, and that is used now around the world as the common inclusion criteria for somebody for VV ECMO. But mind you, this trial was not actually designed to find out what's the best indication for ECMO. This is just the indication they choose. So a patient who has a PaO2 by FiO2 ratio below 50 millimeters per mercury for more than 3 hours has a clear indication. PF ratio below 80 for more than 6 hours, or patients who have severe respiratory acidosis, high CO2, and respiratory acidosis for more than 6 hours could be included as well. Most patients were included with this indication of below 80 millimeters of mercury. Some patients we also include and put on ECMO where we cannot do lung protective ventilation. In these patients, we would try everything else. So we surely would do a CT scan, we would do bronchoscopy, we would do a PEEP trial, we would do proning. So we would try everything to improve these patients. If not possible, and we continue very aggressive ventilation for more than 12 or 24 hours, we would consider ECMO. You see an example here. She was a young lady with a staphylococcal aureus, sepsis, and multiple abscess formations within her lung. And we knew we would not be able to continue aggressive ventilation, so she was put on ECMO. Very important, before you put somebody on ECMO, always make sure it is treatable. If you put patients on ECMO who have untreatable terminal pulmonary disease, you will not be able to wean them, and then your only option or chance would be lung transplantation. So if there is a realistic chance for lung transplantation, you may put terminal lung disease on ECMO. If not, don't do it. Of course, your conventional ICU therapy must be done best possible. That's always a prerequisite. You should not have contraindication. The main contraindication actually is left heart failure, because in this case, you would need VA ECMO. Easier, this was what Dan Brody, the coming president of ELSO, already published in 2011. PF ratio below 80 with a PEEP above 15 centimeters of water, or uncompensated, uncompensatable respiratory acidosis, pH below 7.15. You have an indication for VV ECMO. Let's look at the outcome a little bit. And this is now from the Eolia trial, which probably is known to most of you. Again, the inclusion criteria about 250 patients were included, prospective randomized controlled trial. And looking at mortality at 60 days, you see the Ecmo group had 35% mortality, the control group 46% mortality. This was not significant. P was 0.07, so strictly speaking, just looking at mortality, there was no significant advantage for the Ecmo group. However, if you look at those who had treatment failure at 60 days, and treatment failure meant either you died or you had to be switched to the Ecmo group, and I think there were more than 20% switched from the control group to the Ecmo group. So treatment failure at 60 days, there was a significant advantage for the Ecmo group. 58% in the control group either were switched to Ecmo or died. After that, actually, the results from the Eolia trial and from the CESAR trial, which was from 2009, were taken together in a meta-analysis. And now we have 429 patients. Primary outcome was 90-day mortality. And you see there was now a significant advantage for the Ecmo group, 36%. 90-day mortality in the Ecmo group versus 48% in the control group. That was significant. There was a significant risk reduction to 0.75 in favor of the Ecmo group. Looking at rescue Ecmo and treatment failure, as I explained to you before, 17% of patients were actually switched to the Ecmo group. And if you take treatment failure as the final outcome, there was actually an even higher risk reduction. So with this meta-analysis, and I think better data we probably will not get in the near future, with this meta-analysis, I think most intensivists now think that VV Ecmo is something, if you select your patient well, which will improve outcome. Interesting for me was subgroup analysis from these meta-analysis, and it seems that younger patients profit more. They were far more in favor. On this side always favors Ecmo, on this side favors conventional. Overall, there is a significant advantage for Ecmo, but there is some groups which profit more, and this is younger patients. These are patients with less organ failures, important. Now, if you look at those who have 3 or more organ failure, they did not profit from Ecmo. So don't put patients on Ecmo who are in profound multi-organ failure for several days already. They will not survive. And interestingly, also those who did not have very severe hypoxemia, those with a PF ratio above 68 actually profited more compared to those who had a lower PF ratio. Interesting data. Those who are not as sick probably profit more when they go on Ecmo early. What are the physiological mechanisms of Ecmo? Why do these patients have a better outcome? Well, one very important is we improve oxygen content in the blood. We increase the partial pressure of oxygen, decrease tissue hypoxia, probably have a better neurological outcome. But also importantly, we decrease carbon dioxide, we decrease acidosis, which is very bad for all organs, and we also decrease right ventricular afterload by decreasing CO2, because the resistance of the pulmonary vessels will go down. We can, of course, do more protective ventilation and decrease ventilator-induced lung injury, and there is some data that we may also reduce diaphragmatic myotrauma. Importantly, by decreasing the aggressiveness of ventilation and decreasing right ventricular afterload, we actually decrease right heart strain. And what we often observe, and you can see here in more than 300 patients, we can actually reduce noradrenaline by initiating VV Ecmo. So this is noradrenaline in milligram per hour before Ecmo, and this is on day 1, highly significant decrease in vasopressors because the right heart has less strain. The effectiveness of what we do in clinical practice, I just briefly show you here. This is the oxygenation pre-Ecmo, day 1 to 3 on Ecmo, and then towards weaning. So we can come into a safer range. Then you cannot expect to have an improvement every day. Of course, first your pneumonia has to heal. We are very effective concerning CO2 removal. We start on average above 60 in our patients before they go on Ecmo. And we have to be careful not to decrease it too much on day 1. and we can decrease tidal volume. This is a large variation. Yeah, on average, we go down to 4 mils per kilogram. There are some patients who have 2 mils per kilogram, others have 5, but we can do much more protective ventilation. I showed you noradrenaline before. Now, before we close this first chapter on respiratory support, let me just briefly go into CO2 removal. Why that? Because this is, of course, a much discussed topic. There are many, many patients around who could potentially profit from CO2 removal. And there have been a few studies, and recently a randomized control study has been published. So from the Supernova trial, we know already that CO2 removal is possible in moderate ARDS. This was a pilot trial in 95 patients, looking just within a short period whether it's feasible to do CO2 removal and whether it's safe and whether we can do ultraprotective ventilation by CO2 removal. And they actually found in this pilot trial a significant reduction of tidal volume from 6.1 mils per kilogram body weight to 4. They found a significant decrease in driving pressure, delta P, from 13 to 9 centimeters of water with a stable CO2. That means we can do a more protective or an even ultra protective ventilation when we do CO2 removal in parallel. There have been a number of complications, more or less severe. They did not look into very much detail concerning complications. That is why a randomized controlled multicenter trial in the UK was started in 2016, actually prematurely closed in 2019. They had two groups, lower tidal volume ventilation with CO2 removal versus conventional protective ventilation. They included 412 patients, had to terminate the trial early for futility, and all-cause mortality was the primary endpoint. Ventilator-free days on day 28 was the secondary endpoint. If you look at the baseline characteristics, these were patients with a PEEP of 10, with a median plateau pressure around 26, the driving pressure of 15, and a PF ratio of 118. So they had, let's say, a moderate ARDS. So there are many patients we have in our ICUs with moderate ARDS. Would they profit from doing CO2 elimination? You see, yes, we can do more protective ventilation. This is tidal volume, day 2, 3, 4. This is driving pressure along the course. And actually, they were able to decrease tidal volume by 2 mils per kilogram on day 2. They were able to decrease delta P by -3 centimeters of waters on day 2. But if you have a closer look already, they had to increase PEEP slightly, but significantly. And PF ratio decreased in these patients. And if you look at outcome, 90-day mortality, we have almost the same outcome, no significant difference. The Ecmo group, 41.5% mortality. At day 90, the ventilation alone group, 39.5% mortality. So no significant difference. Looking at vent-free days, actually the control group was better. They had 9.2 days vent-free on day 28, so they were weaned faster. And they had more severe adverse events in the Ecmo group. So there were 31% severe adverse events in the Ecmo group versus only 9% in the conventional group. And there were actually 9 patients versus nil patients within the intracranial hemorrhage in the Ecmo group. So significantly more severe bleeding. I just wonder whether I can get rid of that. No, I can't. So the question is future of Ecmo. The REST trial, maybe that was actually prophetic name for a trial because it meant Ecmo will now rest in peace and will not be used anymore. Question mark. Well, I'm not so sure. What we have to improve. First of all, we have to have better machines which have less side effects. Bleeding and thrombosis is the most common side effects, and these are not balanced currently by the benefits of the machines. Another problem is when we have smaller tidal volumes, we increase atelectasis building in these lungs, and we have more hypoxemia, which requires more PEEP. There is probably an increase of respiratory drive with smaller tidal volumes, which might require more sedation, and then weaning is more difficult. So overall, I believe for the future, we need improved techniques which are more efficient and need less anticoagulation, and then we may discuss CO2 removal in ARDS again. So to summarize that first part, VV ECMO 2022, sorry. Always remember it's no causal therapy. However, you can secure vital gas exchange. It gains times. It allows protective ventilation. It decreases ventilator-induced lung injury and is also able to decrease vasopressors. You may have potentially severe complications. Therefore, you have to choose the right indication, and very important experience is needed. Concerning ECHO, we will see what the coming years will say. Second part, and I think I have to be a little bit faster, VA ECMO. This was actually the first successful cardiac ECMO, which was done by Bob Bartlett. I got this slide from him. This was done in a newborn child put on VA ECMO because of cardiac failure post-operatively. And it was actually the child had acidosis and very low arterial pressure and was on cardiac bypass for 34 hours and survived it all. So this was in 72, 50 years ago, the first child that survived VA ECMO. Today, the numbers largely increase. So this is from a German registry, dates back to 2015. So 2022, we have much higher numbers, but included were 8,351 patients, mean age, and this is around the same in all VA ECMO, 62 years. Almost half of the patients had prior CPR, and 30-day mortality, was 61%. Interestingly, mortality did not change over time. However, patients have more comorbidities. If we look at the European guidelines for diagnosis and treatment of acute heart failure, you see in 2016, you may consider short-term mechanical circulatory support. So it was a may consider indication. In 2016, in 2021, actually, we have now should be considered, though from a class 3 indication, it came to a class 2A indication. And by now in well-selected patients, actually short-term mechanical circulatory assist devices should be considered in patients with cardiogenic shock. Always remember, and they say already here, it's a bridge to recovery, it's a bridge to decision, especially after resuscitation, and it may be a bridge to a long-term ventricular assist device in several patients. What is in principle an indication to put a patient in cardiogenic shock on a mechanical assist device? We all know there is not much we can do with medicines. We can give doses of vasopressors, of catecholamines, of inotropes, but they are not very effective and they actually take out the last part of the heart. So if the heart is not working anymore, we need a mechanical assist device to support this pump. And generally accepted when you have a patient in cardiogenic shock, systolic blood pressure below 90 for more than 30 minutes and or need of catecholamines. And it's important, this is and signs of insufficient organ perfusion, the confused patient, cold, clammy skin, oliguria, lactate is increasing, you may have pulmonary edema, you do not have contraindications, then in principle, you have to consider, is this a patient who should go on assist device? The intention of all these assist devices is to improve oxygen transport capacity, to avoid or to treat multi-organ failure. And if we go back to our oxygen transport capacity, DO2, then this is the content of oxygen multiplied by cardiac output, multiplied by 10, or hemoglobin. You need sufficient hemoglobin, you need sufficient saturation, and very important, and that is for VA ECMO, you need sufficient cardiac output. So even if you have enough saturation, enough hemoglobin, but no cardiac output, the oxygen will not be transported to the organs. And in that case, you need a second pump to improve the cardiac output. And the indications actually are manifold by now, all forms of cardiogenic shock, electrical storm to be able to bring the patient to the electrical lab, post-cardiotomy syndrome, failed PCI in the cath lab, or bridge 2 or post-transplantation. We have patients with right heart failure. We put on ECMO. I show you briefly towards the end some data on pulmonary embolism. We have a combination of cardiorespiratory failure when we can use VA ECMO, and of course, towards the end, the resuscitated patient with refractory cardiac arrest, whom we put on ECMO. Remember always, preservation or restoration of sufficient organ perfusion and oxygen supply is our goal. Not only perfusion of the brain, but also of the heart, because the heart has to recover as well. So has your guts and has your kidney and have your legs. How do we cannulate our VA ECMO patient? Well, generally we do it percutaneously. Very rarely we have to do surgical cannulation. Always, no matter whether you do bilateral or unilateral cannulation, ultrasound guided, we cannulate above the bifurcation, and we use, if we can compare both sides, we use the larger artery for cannulation for the arterial return cannula. If you're not sure which vessel we have punctured, we actually put in a sheet and take blood gases to make sure in which vessel we are. And we actually would then implant secondary and antegrade perfusion if it is needed. There is about 20% of patients who don't need it, then we don't put it in. But I would say around 70 to 80% of our patients actually need an antegrade perfusion, which you can see here. This is a short antegrade perfusion, which perfuses the leg. Whether we do bilaterally or unilaterally depends on the patient. I would say bilateral is preferable. Why that? Because it's easier to remove the cannulas later on when you go into weaning, and you might have a better leg perfusion if there is only one cannula and you do not have impairment on the arterial and potentially on the venous side of one leg. Unilateral, nevertheless, we sometimes do, especially in ECPR situations. So you cannulate, you have one vessel, you're not sure where you are, then you may just puncture 1 centimeter medially to it to find the artery, to find the vein. There is a number of major problems associated with VA ECMO. I cannot go into detail. We may discuss later on, yes, which is cannula associated, which is the Harlequin syndrome, which is the loading, the increase of afterload of the left ventricle, which is the problem of monitoring of our organ functions, which of course is local and systemic bleeding and maybe technical failure. Just to summarize, you have to be very much aware of what can happen. The management of these patients is very complex, much more complex than in lung failure, in VV ECMO. You need a lot of experience. You should definitely have a cardiac surgical department on your side, and you should closely cooperate with an experienced center, which might take over your patient. What is the outcome in VA ECMO? Well, generally speaking, it's worse than VV ECMO. In VV ECMO, you could probably expect outcomes between 60 and 70% survival. In VA ECMO, it will be worse. Coming back to this German registry, what you can clearly see, if patients are younger and had no prior CPR, they have a better outcome. So no prior CPR, and young patients below 65 years of age, down here in green, have the lowest mortality. Those who are older, above 65 years of age, and had prior CPR have a much higher mortality. So already by selecting your patient, it will depend how much outcome you have. You see again here data from Paris. 94 patients who actually had cardiac arrest were resuscitated, were later on in cardiogenic shock and then put on ECMO. So these are not ECPR patients, but cardiogenic shock post-resuscitation. And you can clearly see those who have a low SOFA score have an acceptable survival, almost 60%. Yet those who have a very high SOFA score, have multi-organ failure in cardiogenic shock, have a very high mortality of more than 90% in a SOFA score above 70. Just briefly, I well remember the times when this was a contraindication. Septic shock was always considered a contraindication for VA ECMO. It's not anymore. Yeah, we know these patients with a septic cardiomyopathy who have a very poor cardiac function, which of course is a big problem in a septic patient, but we know if they survive, the cardiac function very often improves within a few days. And again, there is important data coming from Paris. This is a retrospective multicenter, 82 patients in severe septic shock with septic cardiomyopathy. Over 10 years, they collected these patients. And this is adjusted and non-adjusted survival here in red. These are patients who were put on VA ECMO. And this is a historic control group not being put on ECMO. And there was a clear advantage in favor for VA ECMO. So VA ECMO is probably associated with improved survival in patients with sepsis-induced refractory cardiogenic shock and should be a potential indication for VA ECMO. What about pulmonary embolism, VA ECMO and pulmonary embolism? There is several centers which published the results. University of Kentucky had a survival of 53%. University of Maryland had even a survival in 20 patients of 95%. Massive pulmonary embolism with right heart failure. Here in Regensburg, we have put 75 patients with pulmonary embolism on ECMO and have a survival of 47%. So it seems that VA ECMO can be an effective tool to optimize end organ function as a bridge to recovery or intervention with potentially excellent outcomes. What is new now, and what we have now used in 8 or 9 patients, this is a new device, a thrombectomy device, which came from the US. Regensburg was the first to use it in Europe. And you can actually, you have a rather large catheter which you put into the pulmonary artery. You see it here. Now, this is a 24 French catheter placed into the pulmonary artery, and you can suck out the clots, fresh clots with this catheter. You cause a vacuum with this syringe at the back. You suddenly release your vacuum and you actually suck out the clots. You see an example here. This was the right heart before removal of clots, a patient on ECMO. And this is immediately after the intervention, the right ventricle dramatically decreased in size. And you can imagine the cardiogenic shock was almost immediately relieved. So we now use ECMO actually to bridge the patient to an intervention in the cath lab to remove the clot. What is the outcome here in Regensburg? From 2006 to 2021, we had 1,200 patients on VA ECMO. These are those we are talking about in a second. 417 patients resuscitated, refractory cardiac arrest were put on ECMO during resuscitation. 30% were discharged. Those who had resuscitation and cardiogenic shock afterwards, 53% discharge. Low cardiac output, but never resuscitated, again, 53% discharge. Interventional procedures like PCI or a TAVI procedure and resuscitation. These are significantly older, these patients, and 43% are discharged. And these are the classical VA ECMO patients post-cardiac surgery. More than 300 patients you cannot wean from the heart-lung machine. They are put on ECMO and brought to the intensive care unit, 34% discharge. So not too bad, almost 50% of those who had not been resuscitated are discharged with VA ECMO. Let's talk a little bit coming towards the end about eCPR. What you can see, numbers of cases increase over the years. And these are actually data from 2014, between 400 and 500 reports to the ELSA registry per year. I just looked up in 2019, there were already 2,000 cases. So eCPR increases massively. And looking at the survival, it does not change. It remains around 30%. And mind you, this is almost all in-hospital resuscitation. What is the suggested criteria for eCPR? Just briefly, if you do not achieve ROSC, despite 15 minutes of conventional CPR, then you should start considering eCPR. And of course, your cardiac arrest should be of cardiac origin. I'm not going into contraindications now, we may discuss later on. These are suggested criteria for pre-hospital eCPR selection, age below 65 years, witnessed, very important, witnessed arrest, bystander CPR, shockable rhythm, no flow times below 5 minutes, ability to initiate eCPR within 60 minutes of collapse. So if you have actually these criteria fulfilled, you can expect a survival if you're an experienced center around 30%. I'm going to show you different data now. These are registry data again, and I'm just showing the take-home figure. This is from Paris, out-of-hospital cardiac arrest patients. 13,191 patients are in this registry. 12,000 had conventional CPR, 500 had extracorporeal CPR, eCPR. Looking at survival, there was no difference. Survival to hospital discharge. Why is that? Well, if you look a little bit more into detail, and if you allow me some criticism, in 11% of eCPR, there was failure of cannulation. The median, and that's the median time, that means 50% or above that, median CPR time to ECMO, 90 minutes. That's definitely too long. If it takes you 90 minutes until your ECMO runs, you will have a poor outcome. Mean lactate very high. Mean time on ECMO, quite short. So most patients probably died within 1 day. Looking into non-shockable rhythm, only 2 of 112 survived. Yet if you look into initial shockable rhythm and ROSC, 11 of 81 survived. So again, I think this shows that experience is crucial, that timing is crucial, and selection of patients is crucial. There is a little bit more data now recently. This is just a small trial, but was published in The Lancet from Dr. Yiannopoulos. And he actually had a prospective randomized control trial, but only very few patients, 30 altogether. What he could show, and that is why the trial was prematurely stopped, those who were actually implanted ECMO in the emergency department. So patients were rushed to the emergency department and then randomized pro or con ECMO. Those who did not get ECMO all died, and those who actually received ECMO, 6 of 14 had a long-term survival. So significantly better outcome with a good neurological outcome if the ECMO was implanted with ongoing resuscitation in the emergency department. And even more recently, now Jan Belolavec, the former president of EuroELSO, published his trial from Prague, again randomized prospective clinical trial, 7 years, 256 patients included. Again, presumed cardiac origin, more than 5 minutes CPR witnessed, younger patients. And you see overall during that time, more than 4,000 patients who had to be resuscitated, were assessed for eligibility, but only in the end, 264 were randomized. Just briefly to show you the outcome. The invasive strategy meant the patient was actually rushed to the cath lab, and in the cath lab got ECMO implanted, and then a PCI was done. There was a survival with minimal or no neurological impairment after half a year in 31.5%. This was numerically better than in the standard strategy group, but was not significant. Why? Because they had actually an excellent outcome for the standard strategy group. A 22% good neurological outcome for out-of-hospital resuscitation is excellent results. That probably shows that they have been very effective in training their staff there. And again, important, time is brain. This is old data from Taiwan. They have done a lot of eCPR. Just briefly to show you, this is good neurological outcome, 60% here, and this is time to ECMO. So if it takes you only 20 minutes until your ECMO is running, which is exceedingly fast, then you can expect on average 60% good outcome. However, if it takes you more than 60 minutes, your outcome will drop down to 20%. So the goal should always be to remain below 60 minutes, and that is why they hesitated to recommend ECMO for out-of-hospital CPR. To summarize and to come to an end, all 3 parts, I think VV ECMO nowadays has become an accepted part in the management of severe ARDS. It effectively supports gas transfer. It definitely reduces stress and strain on the lung. Importantly, enhances right ventricular function, and thereby we may reduce the need for catecholamines. VA ECMO is increasingly used in the management of cardiac failure, and actually numbers for VA ECMO in Germany are far higher than in VV ECMO. It does restore blood pressure and organ perfusion. It stabilizes my patient temporarily. Remember, it's always a bridging tool, hopefully to recovery. eCPR, just briefly, may be helpful, I think, in well-selected situations. And do remember, ECMO is a complex treatment. It is very complication prone. We could not talk about this now. Therefore, you need experience. You have to select your patient right. The timing must be well done, and cooperation is crucial. Thank you very much.
So thank you, Professor. It was indeed a very lucid and very interesting discussion, and I hope that you have been able to depict the complete picture of ECMO, right from installation to the troubleshoots and all that. So I think we are now open for panel discussion, and I would like to invite my friend Dr. Gunadhar also, to initiate the proceedings for panel discussion also.
Yeah,
Yes.
Thank you. Thank you, Akhilesh. Thank you, all the panelists. Thank you, Professor Muller. So there are a few questions first in the chat box. So let's take up one by one. So one thing is, one questions being asked is best alternative for anticoagulation in case of thrombocytopenia less than 50,000. So I would like to answer Professor Muller and followed by all the other panelists. So role of anticoagulation and what anticoagulation is being used in your center, sir.
The important question, I believe, is there a reason for the thrombocytopenia? So you would always have to exclude heparin-induced thrombocytopenia, because if a patient, and this is about 3% of patients actually develop heparin-induced thrombocytopenia, then definitely you must not continue anticoagulation with heparin. That actually is the reason why we switched to agatroban several years ago in VV ECMO, to avoid this risk of heparin-induced thrombocytopenia. Always the diagnosis of heparin-induced thrombocytopenia is time-consuming. Therefore, in case you're in doubt, you have to switch to an alternative, which actually is agatroban or bivalirudin. Generally speaking, should we still do anticoagulation in somebody below 50? Is a good question. The risk of intracranial bleeding increases. So actually, we may decrease our anticoagulation. We may run on an APTT of about 40, 45. If the patient has signs of bleeding, we actually stop anticoagulation. When do we substitute? Another good question. There's no prospective data. I know centers who want to have their platelets above 70 or 80,000. If you want to have that, you have to substitute a lot. We generally would accept 20,000. In a septic patient, we would try to be above 30,000. Of course, we substitute when there is signs of bleeding. Okay.
Thank you, sir. For the question is open to other panelists like Dr. Nilesh and Divan, sir. Sir, what is your protocol in the center, sir?
So our protocol is slightly different. What we do is that we generally try to maintain a platelet of around 70 to 80,000 as has been recommended by the ELSO. What we have also seen that it does decrease the incidence of intracranial bleeds if you maintain in that range. For example, in our data now, whatever ECMOs we have done, we have had only 3 intracranial bleeds in the last 5 years. So that is one thing which I feel that maybe a little bit higher than 50,000 should be the target. And that's what the ELSO says. Second, if we find thrombocytopenia, as Thomas said, it is very important to know the cause, because normally the cause is sepsis or drug-induced thrombocytopenia, or there may be some component of hemolysis. So we have to rule out each and other component before you actually blame heparin for the thrombocytopenia. As Thomas said, the incidence of it is quite low. So that's why you have to rule out other causes. In our situation, we have not shifted to argatroban or bivalirudin. We still continue with the heparin. And in case we have initial signs of bleeding, in fact, we have run heparin-free ECMOs for days together now. In fact, we have one patient on ECMO right now who had a massive intracranial bleed, was operated for raised intracranial pressure in the form of neurosurgical intervention. And we had to do a lot of interventions to actually maintain his anticoagulation and the platelet. So it is tough when they bleed, but it's better that we maintain a higher platelet so that when the bleeding happens, it's a very difficult situation I would say, unruly conversation with the family. So we try to maintain around 70,000-80,000. But heparin is still our main protocol for anticoagulation.
Thank you. Thank you. Dr. Arpan, can you enlighten regarding this protocol?
Actually, over the period, last 5-6 years, for different indications, we have seen different things. As less than 50,000, we stop heparin. This is for clear cut. But substituting platelets, we initially kept more than 1 lakh. Then we came down to 70,000. Then we came down to 50,000. Then we came down to 20,000. As Dr. Muller rightly told, that too much of platelet substitutions were required if you want to give 50-70,000, because in COVID most of us has run in ECMO for 2 months, 3 months, 4 months, and thrombocytopenia is a part and parcel with this long ECMO runs. So if you keep on giving the SDP single donor platelets or platelets, you are going to transfuse like anything. But obviously, for any bleeding reason, or the patient if is showing any bleeding, or you want to do some procedures, then you I transfuse platelets. We started accepting platelets of 30,000 if there is no bleeding, and obviously we stop all the anticoagulations below 50,000. Heparin-free ECMO is a good alternative for that, and we did not give any patients on bivalirudin, and they have not suffered any kind of clots because of that. And we can show the oxygenators after 80 days of ECMO. Out of that, 50 days were heparin free, and they are absolutely fine. There is no clots, and many times the clot has happened just after putting on ECMO after 3 days. So that it differs from different, but for the sake of reducing the transfusion and all these things, we have kept down this platelet if the patient is not bleeding or any procedure is not done. Bivalirudin I have used in one patient. He was a doctor and he had specific thrombocytopenia, this HIT diagnosed, and he had multiple clots in the system. So for that patient, I have to use bivalirudin, but he didn't make it, and probably because he died of some other causes. But bivalirudin I have not used, but it has been very much in use with the current literature is coming with pediatric patients. They are telling it's easier to titrate and lesser chances of bleeding than the heparin. But still we are with the heparin and we are continuing with the heparin, even with the pediatric ECMOs.
Thank you, sir.
What should be the target ACT or APTT? Because I've seen increased incidence of bleeding after heparin as an anticoagulation, and we had to switch over to bivalirudin also. I mean, there is still a lot of debate pertaining to the ideal ACT or APTT values, and I would like to know from all the panelists and the speaker as well as to what should be the ideal.
Actually speaking, actually speaking, after 24 hours, we have stopped measuring the ACTs and we have switched over to APTTs. If you maintain an APTT of 1.5 times around, I think that is the safest one. And we try to maintain a little bit of higher flow in VV ECMO for the longer run. If you want to, the prothrombotic period, the chance is very low with the higher flows. So if you jollibly maintain a liter of 4 liter, 3.5 liters continuously, and for the weaning also, you are not coming down on the flow in the VV ECMO, then the heparin thing doesn't disturb too much. If you maintain in 1.5 times of APTT, I think it's fine. Only problem is when the sepsis happens and you have clot load, clot burden because of different reasons. You have pulmonary embolism, if you have different things, then there is a problem happens. So 1.5 times for Indian population is well anticoagulated in my experience.
What about Dr. Nilesh? What is your experience and what anticoagulation you use for heparin allergy? That is the question asked by Dr. Sanjeev.
Yeah, hi. Thanks for the question. I would agree with my previous panelist, and we essentially target platelets up to 50. Below 50, we get jittery and we stop the anticoagulation. I would say thanks to the technology and the technological advancement with the circuit, as well as with the new cannulas which are heparin bonded, you could just go without heparin for days together. The highest we have gone is up to 28 to 30 days without heparin. In fact, I remember a patient with, this was in Australia with good pastures, which we did without heparin for almost 32 days. As far as the alternative to heparin is concerned, and we go with ACT for the first 72 hours, followed by which we go with ACT and the APTT, sorry, the targets essentially are 1.5 times, similar to what most of us do. Alternative, I haven't used bivalirudin here, but I've used it in Australia. I have used fondaparinux in almost around 8 to 10 patients whom we suspected around hits, and we managed to go around with that as well pretty well. We haven't used, our center does not use bivalirudin quite frequently.
Okay. So, Dr. Subhadeep, I think you can share your experience of 20 patients and what is the chances and incidence of your IC bleed, and what do you feel? Any heparin substitute will help. Subhadeep.
Yeah, sorry, unmuted myself. Thank you so much, Dr. Gunadhar. So the thing is that in our center, we use mostly heparin as a kind of anticoagulation of choice. Thrombocytopenia we come across often, as Dr. Arpan has highlighted, in somebody who is on ECMO for a little bit of prolonged duration, or sometimes even in the earlier phase of only. But 2-3 things probably that I need to tell is that it is the etiology of the thrombocytopenia that is most important to consider as of now. If the thrombocytopenia is a part of DIC, then again it will be kind of massacre. But most of the time, what happens, despite having a kind of thrombocytopenia, especially in the sepsis patient or somebody especially in the COVID patients, they tend to remain hypercoagulable. So even despite having a platelet count around 30-40,000, they don't tend to bleed at all. So we sometimes tend to do thromboelastography to see the dynamic coagulation parameters of the patients, and we see that even the platelet count is in the range of 20-30,000, they are actually hypercoagulable, and in that case we do not transfuse. But in that case, sometimes if we do a TAG and the MA is less than 30-40, probably in that point of time, irrespective of the platelet count, we transfuse. And anybody who is bleeding obviously is an indication of transfusion. In our centers, again, we had a little bit of quite a bit of intracranial bleeding complications. 2 or 3 patients developed intracranial bleeding complications in our centers who died of intracranial bleeding. But again, we try to maintain the APTT within the range of 1.5 to 2 times the maximum. And most of the times, even if somebody is bleeding, we have stopped the heparin most of the time. And even especially in the high flow setting, they do not, even the chances of the circuit clot is very minimal, especially in the presence of the heparin coated circuit that we normally use.
So if we are worried about bleeding complication and worried about thrombocytopenia related to heparin, so the best way is to probably keep the flows little high and accept the flows of around 4 to even 5 liters also. I don't think we will be
so
able
that is
to
possible.
have much
That is possible in the VV ECMO, somebody with an ARDS, but sometimes the VV ECMO we do not require that much of flow. So sometimes around 1.5 2 liter of flow is required in the VA ECMO. So in the VA ECMO, obviously the chance of bleeding complication is much higher. Especially we use the heparin APTT target also remains a little bit higher, especially in the VA ECMO. Again, in the ACOR setting also, probably the requirement of the heparin is a little bit higher. But VV ECMO, again, if we maintain the APTT even less than 1.5 times normal with a flow of 4 to 5 liter per minute, probably that doesn't cause any kind of problem in the circuit.
Yes, absolutely. Sir, Professor Muller, sir, one question is regarding the citrate. Sir, any experience regarding the citrate anticoagulation, sir, on ECMO?
I think there is no role for citrate on ECMO, with one exception. When you do in parallel renal replacement therapy, you have a patient who is bleeding, you do not use heparin, you may use your citrate on your renal replacement therapy. but you could not use citrate for anticoagulation in ECMO because the flows are far too high and the need for citrate would be far too high. So in renal replacement, we do a maximum of 200 mils blood flow, which we would do anticoagulation with citrate. In ECMO, you go up to 4 liters. So I think citrate is not working.
Divan sir, what is your choice in heparin allergy or patient who developed HIT? How do you manage, sir? In heparin-induced thrombocytopenia or heparin allergy?
As I told Dr. Gunadhar, we go to heparin-free ECMOs, as Dr. Arpan was telling. We increase the VV ECMO flow by about 20 to 30%. So if somebody is on a 3.5 liters of flow, we go to 4 liters. And we try to maintain the RPMs and then do a heparin-free ECMO. But in the meanwhile, we diagnose the cause. Suppose there's a hit, and now we know that we have to use some other anticoagulation. Then in our protocol, although we have never needed to use it, we have thought that we'll either go with evaluridine or ergotamine, as Thomas was telling. But fortunately, till now, we have never used it.
Thank you, sir.
There is one question on the chat box. I mean, there is a lot of debate pertaining to the ventilator strategy once the patient is on ECMO. Some people still ventilate the patient, and some people still keep the lung at rest, and and some patients are still sedated, even patient being on ECMO, and some centers prefer to keep the patient awake and mobilize and all that. So what should be the exact strategy and how we can streamline this problem? I mean, we keep the patient sedated unduly for prolonged duration, and we end up having critical illness, myopathy, neuropathy, and then prolonged stay and all that. So what I know, it can be protocolized according to the center to center, and the personalized care should be the option. But what could be the best strategy while ventilating these patients who are on ECMO, and we want to win them as well as early, and ventilator strategy also? Please tell us. I'm from Dr. Thomas Muller. I would like to hear, and then I would request all the panelists to give an opinion on this also.
You saw already that most of us started to smile a little bit because nobody knows the best answer. I think it depends what you do. It depends on so many things. So there is in principle, either you do lung rest, complete lung rest, low PEEP, low FiO2, low tidal, very low tidal volumes, and you completely depend on your ECMO. Or what we do, and I explain in a second why we do it, we try to maintain a little bit of a lung function as much as possible within safe ranges. And we try to keep the lung open. So we would probably stay with our PEEP on ECMO initially the same as before ECMO. If I have massive capillary leakage and severe septic shock, I might have a PEEP of 20, and I would remain at 20 initially. Later on, we decrease when the patient improves. What we do is we try to reduce oxygen below 60%. We definitely try to reduce maximum pressure. And over the years, we actually came down. Nowadays, my goal is to be below 26 centimeters of water maximum pressure. Delta P is always below 10. And tidal volume depends on the patient, depends on the compliance of the lung, maybe 2 milliliters, maybe 4 milliliters. Why do I not do lung rest? First of all, because there is no proof that complete lung rest actually improves outcome. There is some data which shows that a little bit higher PEEP may be better, but apart from that, we have no randomized controlled data. The second is when I decrease in such a patient who has a PEEP of 20, when I go down to a PEEP of 10, immediately he will white out his lung. He will develop massive atelectasis. The lung will not participate in gas exchange anymore. That means my patient would depend completely on ECMO. And that is a situation I don't like. Why not? Because I don't know what your nursing is, but in Germany, one nurse has to deal with 2 patients, no matter whether he's on ECMO or not. That means my patient on ECMO, 50% of his time, he is alone. And in case there is an acute problem with the ECMO machine, I will not be able to oxygenate him anymore. Also, exchange of the ECMO at night probably takes us 20 minutes or more. So I prefer to keep open what I can keep open within safe limits to be able to still ventilate him in case of emergencies. In a nutshell, but we can discuss 2 hours about that.
Some centers, they prefer to extubate during the weaning phase. I have encountered 1 or 2 cases in few centers. They have extubated the patient on ECMO, and then the ECMO was going on, and then they decannulated subsequently. So any experience regarding that?
Anybody else?
So, hi. So we regularly extubate the VA ECMOs because there you are actually not requiring more of ventilation. Like when we're doing ECMOs for self-pause, or we're doing patients with cardiogenic shock, once they start improving, we extubate them and then the ECMO runs. On VV ECMO, we try to keep them. Our strategy for ventilation is the same as Thomas is telling. The only thing is that after 3-4 days, we try to keep them awake. Once the synchrony is established, we stop down, we come down on the sedations, and the rest of the ECMO runs are the patients are kept awake. But this strategy failed miserably during COVID. I'm sure other colleagues would have observed the same thing. Whenever we tried to wake up these COVID patients, there was a lot of desynchrony. And we also noticed there was higher incidence of pneumomediastinum, higher incidence of pneumothorax. So unfortunately, during COVID, we had to keep most of the patients sedated. I would not say paralyzed, but deeply sedated. So, but in most of the other situations, we would actually keep them awake, but with an endotracheal tube inside. So we don't extubate them. Most of them actually end up with a tracheostomy. So that's why I see no reason, because whatever we may avoid, critical illness myopathy does develop in these patients, particularly if you are running a long ECMO, as we are seeing in VV ECMOs. Only it goes beyond 40 days. So critical illness myopathy does develop, and that's why a lot of them require tracheostomy. So I think once you are in that phase, we are still not extubating any of our VV ECMOs. But VV ECMOs, yes, we are able to take the strength to get them off the ventilator.
So, Dr.
Muniz, your experience?
Dr. Muniz, can you share what about your view on proning on the ECMO who is hypoxic after all the possible therapies?
Well, we haven't yet proned a patient on ECMO, though we are considering it to do in the future. Dr. Muller would be a better person. I think he's currently studies going on in their center in which they are proning patients. There is a lot of interest that is being generated, because just like an optimal PEEP and optimal ventilatory strategy on VV ECMO helps, proning can be helpful in more than one way. It's not just as a rescue measure when the patient is hypoxic on ventilation, but it is now also being seen as a measure to hasten the improvement in the lung function, so that we can shorten the duration of ECMO. So if I'm not wrong, it started off as a rescue measure for for patient who were hypoxic on ECMO, even despite the flow chart if you have read. So it is a part of that. But now it's been perceived as not only as a rescue measure, but also as a supportive measure to hasten the lung recovery and decrease the duration of run on ECMO. But I think, Dr. Muller, your comments, I think you're doing it. You're studying that.
You're doing it more and more. I was quite skeptical in the past, proning patients on ECMO, because I was afraid if somebody would lose a cannula, he probably would die. I think a prerequisite is that you're a center which does a lot of proning. Your staff must be experienced in proning, the right positioning of the patient. So when you're an expert center in proning, I think you can easily prone on ECMO. It works well, and probably Munish is right in saying that we probably hasten lung recovery. It's not proven yet, but there is retrospective data, especially coming from France, that says that A, it's safe, and B, it probably improves outcome. So I think the future will be that proning, again, in selected patients, you don't do it if he is awake, but in selected patients, I think proning probably improves our outcome.
Okay, thank you. So Dr. Appan, sir, so basically the thing, one interesting question is asked, like one patient with H1N1, and he developed this severe ARDS on VV ECMO. Now almost 12 days have passed. lungs are stiff, not tolerating tidal volume above 100 ml, and very high P-plateau pressure. So but the question is from Dr. Deepak, how long should we wait in such kind of viral pneumonias in a patient who is on ECMO?
If that webinar would have happened in 2000 before 2020, I would have been a bit skeptical with 12 days of ECMO. But in 2022, 12 days of ECMO, I'm not skeptical. Continue it. It will lead to organ recovery, because we have developed at least the confidence of running longer ECMOs during COVID. And just previous question, I want to tell you, we have done a lot of proning during COVID on ECMO. Many patients we have proned. We have proper indications of proning we have developed. The patients who are not able to maintain a saturation of more than 85%, even with a good amount of flow, we prone them on ECMO. And it resulted good in few patients. And few patients, the duration also shortened. We have seen that. But it's a resource intensive thing, and you need to take care of that. So coming to the last question, that 12 days of ECMO, if it is not improving, you can ask for proning for 2-3 episodes, just to see whether it is still recruited some lung and hasten the recovery.
Thank you. So, Dr. Nilesh, what are the drugs to be avoided in a patient who is on ECMO asked by Dr. Narendra? So what is your opinion? What drugs?
The pharmacokinetics of drugs, essentially, on the patients on ECMO, I think changes drastically. You require more of sedatives. You have to use, more of lipid soluble agents would be the agents which are more lipid soluble. You require more and more. You encounter tachyphylaxis to the sedatives that you're using. So using, sometimes if you have no alternative than to sedate a patient, you may have to change the kind of sedative agents that you go with, possibly go with less lipid soluble agents. As far as antibiotics are concerned, there is a clear protocol for using higher doses of antibiotics for patients on ECMO as well. As far as drugs to be avoided, particularly, I would say is that you would not give any agents which could potentially cause clotting into the system. So agents like tranexamic acid or anything which could essentially lead to acute clotting of the circuit is something which definitely has to be avoided. But there is a clear guidelines in regards to the pharmacokinetics of the different agents, just changes of the patient on ECMO. So sedatives, antibiotics, and so on and so forth. You have to just adjust the doses accordingly.
What about propofol? Because a lot of people they avoid propofol because of this. But sometimes there is a problem with the membrane. So what is your
so we as a sedatives, our center essentially believes in less is more. So we tracheostomize the patient within 48 hours of ECMO initiation, and we use the least possible sedatives, or we try to keep the patient as awake as possible. Propofol per se, yes, in the short term can be used, but in the long term can cause problems with the circuit. I personally haven't encountered anything, but yes, in literature there have been cases of people having problems with the ECMO circuit with the use of propofol. But my personal experience with this is, I would say, I don't have any personal experience with that.
So there's one question in the chat box. What is the winning criteria, ideal winning criteria in ECMO patient? It differs from center to center, and definitely there should be a resolution in the lung, the disease that has affected. So probably, but apart from that, what are the other essential winning criteria that you would like to incorporate in your guidelines? I mean, if we have to set the guidelines. Over to you, Dr. Professor Thomas Muller, and then other panelists also can give an opinion about that as well.
It's another difficult question, because there's different ways to do your weaning. There's either you remain on high blood flows but decrease your gas flow and mix air to the sweep gas flow, or else, as we do it but others don't, we actually decrease gas flow and blood flow in parallel. So I tell you how we do it, and others may say how they do it. So I want to be with ventilation in a safe range. That generally means my PEEP is below 10, my oxygen is at 40%, my pressures are low, The patient may be supported breathing. And actually, I try to come down with ECMO from the very beginning. So the weaning from ECMO, same as weaning from ventilation, starts from the beginning. And we in Regensburg, we would both decrease blood flow and gas flow. In VV ECMO, we would go down to a blood flow of about 1.5 liters. Not lower, because then clotting increases rapidly. We would decrease our gas flow to 1 liter, then we would switch off gas flow and see how the patient does. Now, when the patient is stable without gas flow, let's say for 2 or 3 hours, then we consider taking out the ECMO. If we are not certain, we may leave the cannulas in place and adapt a renal replacement machine between the cannulas just to keep the cannulas open. Actually, in COVID patients, we wanted to have 24 hours without gas flow before we removed cannulas, because we have seen several COVIDs who seemed to do well for a few hours, but later on they deteriorated and we had to put them on ECMO again. So that's in a nutshell how we wean our patients.
So Dr. Nilesh, how do you go about weaning protocols in your center, and what was the protocol that was followed in Australia?
So depending
Does it
upon
differ?
obviously what type of ECMO you're doing, I mean, weaning definitely for VV ECMO versus VA ECMO differs. If you're talking about VV ECMO, as Professor Miller mentioned, we have to just start thinking about weaning and how aggressive you are, how early you'll have to wean this patient right from the beginning. Our protocol essentially is to come down with the fresh gas flow. We do not come down with the blood flow. So we maintain a blood flow, roughly around 3 liters, and we keep on backing off on the fresh gas flow and simultaneously make adjustments with the ventilatory settings. So if our ventilatory, towards the end, we also switch off the fresh gas flow once we reach a fresh gas flow from 0.5. I think that the last 0.5 weaning patient from 0.5 or less than 1 fresh gas flow is the most tedious and the most, the time when you have to be really cautious. You have to simultaneously keep on adjusting the ventilatory settings. The patient possibly may require a little bit of sedation at that point of time. And once you achieve a situation in which your plateau pressures are still less than 25, your FiO2 is less than 60%, and the driving pressure is less than 15, with a fresh gas flow which has been switched off for more than 12 to 24 hours, this is when we think about decannulating the patient.
So, Diwan sir, very interesting question regarding the hybrid ECMO, sir. What is your experience from Dr. Masood to the panelist?
Well, we have done few. In fact, most of the time, hybrid ECMOs are being used in patients with acute cardiogenic shock and pulmonary edema. So what happens is sometimes when we are starting with, once you have a patient of cardiogenic shock and massive pulmonary edema, we start with the VA ECMO. And as we all know that VA ECMO increases systemic vascular resistance. So it will actually not unload the left ventricle. So left ventricle will be still under strain. And we have seen after 24 hours, 48 hours, if the PO2s in the right radial artery start to go down, we know that the brain and the other major organs are under compromise because of hypoxemia. So the right radial artery cannulation is a must in a VA ECMO patients, because with that we can actually maintain the brain, understand whether the brain is getting oxygenated or not. So in case we see that the PO2 is going down to less than 60, and we know that the lungs are flushed with pulmonary edema, we then put another V cannula, another venous cannula, and we divert the blood into the return cannula into two. One part of it goes into the arterial side and the other part goes into the venous side. Now, after that, it's a matter of jugglery. I would say it's a matter of how much flow you want to send to the artery and how much flow you want to send to the venous. So that's why when you're planning an ECMO, particularly for cardiogenic shock, we always say, please put the largest possible cannula as your drainage cannula, because you never know how things may pan out later on. So in hybrid ECMOs, once we have put a return cannula in the venous side and the VA is already there, we make a Y connected. And as I told, we send the blood back into the artery and the vein. Now, the blood follows the path of least resistance. If we say that now that if we know that hemodynamics takes precedence over oxygenation, we will then clamp the venous side a little bit, and more blood will be diverted towards the arterial return cannula. But if we see that the hemodynamics is stabilized because of the ECMO after 24, 48, 72 hours, and oxygenation still needs to be cured, so we divert more blood towards the venous side, and the arterial side gets less blood. So we have done few cases of hybrid ECMOs, and it's actually one of the very important simulation scenarios also. But it's not easy. You have anticoagulation. During anticoagulation, you put in another cannula, and then other hybrid which we have done is VVV, where we found that suddenly the patients, you see the cardiac output requirements are high, and you need higher flows. And sometimes you may need more cannulas to, not now, but during initial part of our ECMO program, if you have put in a 17 French drainage cannula, and suddenly you need higher flows, you will have to put another cannula for the drainage, because if the patients become septic, the cardiac output goes up from say 5 liters to 9 liters, and 17 French cannula may not be able to make that cardiac output. And we know that even in VV ECMO, to prevent shock, at least 60% of the cardiac output should be taken care by the ECMO. So that's why we then have done a triple V ECMOs also, and we have done VAV ECMOs also as a hybrid condition. But yeah, I think as you mature in your program, as you get more and more patients, these kind of problems will come, and as the teams get more and more trained, these can be encountered. It's not a big issue.
Arpan sir, what is your opinion? ECMO with IABP or hybrid ECMO, sir?
They are all different indications. If you ask me if you are you want to come off bypass and it's a LV problem, and you are putting on VA ECMO, the IABP must be there just to maintain some amount of pulsatility and for future coming off from veno-arterial ECMO. That is a good proposition. For VAV, it's a very useful mode, and many a times you have to change from VV to VAV when your otherwise normal pneumonia patient goes into a shock, or they go into a myocarditis, or they went for an arrest, or they went for a septic shock. So then you had to add some amount of arterial support for that. Or many a times you have started with VA ECMO and you had landed up in Harlequin syndrome, and then you change over to VAV mode. So those three are different indications, but IABP with ECMO is a good position where LV is getting bit of dilated, and you want bit of you want to maintain some amount of pulsatility just to prevent the LV distension and the maintain the aortic valve opening, so that the LV thrombus doesn't form, doesn't this the blood LA pressure doesn't goes up. So it has its different indication. VAV is a good ECMO. We have learned slowly how to manage a VAV ECMO, and we are doing it regularly now. For basically for the sepsis with myocarditis for adults, VAV is a good proposition.
Yeah, and one more question is regarding the thrombosis of femoral artery. So if the femoral artery is thrombosed bilaterally, so in that case, what arteries do you usually cannulate for this ECMO patients? From Dr. Sakuntala to panelist. Either yeah, please.
Our preferred cannula is the artery is axillary, and that's a surgically opened. You have to open it surgically. We have faced it also that both femorals are not thrombosed. They're such small and they're atherosclerotic. The femorals cannot be accessed, and so we have put the axillary. In pediatric patients, the femorals are small, so we have cannulated regularly with the carotid and the jugular for the thing. So if you ask for the adults, the second cannula site is axillary for us, and pediatric patients for the carotid.
So what should be the indication for central ECMOs when we differ it from peripheral ECMOs? Dr. Nilesh, can you highlight on this? There is one question. Yeah.
Central ECMO, obviously, as the name suggests, it's something with the chest which is open already. So will be done by the cardiothoracic surgeons if they are encountering problems while getting the patient off the cardiopulmonary bypass machine. So essentially, indications like failure to get the patient off the CP bypass machine, patient going into intraoperative cardiac arrest, would be few of the indications where you would go central ECMO, central VA ECMO. So essentially, it's done by the cardiothoracic surgeons when they find it difficult or something goes wrong intraoperatively.
Okay. So, but can we convert peripheral ECMO into central ECMO anytime if there is difficulty in cannulations? Do you have had such experience where you have real trouble with handling central ECMOs in that situation?
Well, to tell you frankly, with the place where I was working in St. Vincent's Hospital, Sydney, it's a major heart lung center. So if we were not able to cannulate, we always had the cardiothoracic surgeons as a backup, always. So essentially, if you can't do a percutaneous cannulation, you've always got a surgeon who could do a cut down and do a VA or cannulation. I don't remember a situation in which we, just because we could not do a peripheral cannulation, we had to go for a central ECMO. But yes, patients who were intraoperatively who could not come off the bypass machine, they did come back with a central VA ECMO.
Dr. Muller, do you have such experience of handling such complex cases where you have real struggle managing, inserting central ECMOs?
Not too many, because we are primarily a pulmonology ward. Okay. So all post-operative patients would actually go to the cardiothoracic surgical ward. But in principle, you can do, as Dr. Nilish said, you can convert to a central cannulation. Our patients, we never had to do that because we were always possible to reach some peripheral artery or vein. As said before, our adults, if we can't get the femorals, we use the subclavian artery. But yes, in case you have to do full respiratory support and full cardiac support, of course, central cannulation would be the better one. But still, I think it has a significant risk for complications. So probably whenever you have to go for a central ECMO, your mortality probably is higher. But I don't have a lot of personal experience.
All right.
So my question is to Dr. Munish and Dr. Sugadeep, how to manage the blood flow in hyperdynamic circulation like sepsis?
And how much maximum flow we can achieve? Dr. Sugadeep and Munish. Dr. Munish? Okay, Divan sir. Sir, how do you have to manage, sir? The patient is going into sepsis.
This is actually a very difficult situation. Yes, because the problem here is when the patient is going into severe vasodilatory shock, whatever you may try to maintain through the, I'm talking about, there are three scenarios in sepsis. If we talk out pure hyperdynamic vasodilatory shock, the cardiac output reaches to the tune of 8 to 9 liters. This is a situation where one single cannula, whether even if it's 21 French or 23 French, will not be able to meet the cardiac output needs of the body. So this is an indication where central ECMO can help. There is some data from Melbourne, and there's also some data from Singapore, where in pediatric patients, they have put central ECMOs in patients with septic shock, and they have actually documented 70 to 75% survival. This is actually one paper which says that central ECMO may have a role if you are dealing with extreme vasodilatory shock, because the kind of cardiac outputs that are required in those situations can only be met by the central ECMO. So this is another indication for central ECMO, which is not standard of care, but yes, there's data on that. How do we manage in these cases? As I told you previously also, you can obviously you need to treat aggressively the sepsis part. That's the main reason. But we have had a situation where we have put another cannula, a more drainage cannula to increase the blood flow. These were basically extremely vasodilatory dengue patients. What happens in dengue shock? I'm sure you guys have seen it extensively, that it's not a vasodilatory state, but there's a lot of third spacing. So what happens that because of the third spacing, we're not able to generate enough flows. So, but we have tried triple V cannulations to generate more flow, but it has not helped. Most of the patients still died. So we remember 4 patients of dengue shock and septic shock, which we tried. Now we do not put vasodilatory patients on ECMO. As a protocol, we do not offer them VV ECMO because we have seen that whatever you may try, you can try multiple ways to increase the flows. You can try beta blockers, you can try hypothermia, we can try every possibility to decrease cardiac output, but still ECMO is not able to help in these scenarios. So that's why I told it's difficult, but yes, ultimately it's all about aggressive treatment of sepsis. ECMO peripheral has very little role in vasodilatory shock because of sepsis.
So in such a desperate situation, can we insert another cannula, like we should convert it into VVV ECMO or something like that?
We have done it. Yes, we have done it, as I told you, but we have no experience to say that these patients survived.
Okay.
I remember distinctly there was this gynecologist doctor who was referred to us with a bad shock, and the femoral artery size was so small, and the venous size was also small. We still tried to cannulate it, could not generate enough flows. So whatever we may do, they end up in mortality. So that's why I'm saying this is an area which is where we feel peripheral ECMOs may have very, very little role. I'm not talking about septic shock with ARDS. I'm not talking about septic shock with myocarditis. I'm only talking about hyperdynamic vasodilatory septic shock.
Fantastic. ECMO is very important, and when we wean, and rehabilitation has been an important parameter, which we all forget that even if the patient has come out of ECMO, the 50% job is still not it over probably. So, Dr. Thomas Muller, you have extensive experience of rehabilitation. Can you throw some light on the rehabilitation strategies when the patient is being weaned from ventilator or weaned from ECMO? Can you highlight a few points on rehabilitation strategies in these ECMO patients?
Yeah. So I think one important thing is, and we have all touched this now, is to get your patient awake as soon as possible. The worst is, I remember we started around 2006, 2007, we started Awake ECMO. And at that time, I went to the US, and at a conference, I reported our experience on Awake ECMO, and they were all surprised because they had not done it before. So in the past, all these patients were deeply sedated and were not allowed to move, maybe have even muscular relaxation. So we now know that you have to treat your ICU patients differently if possible. And again, I agree, Sandeep, COVID was very difficult to keep them awake, but in general, get them moving, get them awake as soon as possible, even when the ECMO is still running. When they come out of the septic shock, decrease your sedation, go into spontaneous supported breathing, mobilize them with ECMO if possible. I think that's the most important to get them rehabilitated. When you do long run ECMOs, as I heard you all do, our longest run was almost 200 days. I today think you have to select very well in whom you do it and in whom you don't do it. Because whatever you do, they will be in a very bad shape after such long runs. And I believe only young patients with not many comorbidities are actually able to come out of that. You will need a hospital which supports you in your rehabilitation afterwards. Our ICU is too small, so we generally would then transfer these patients to specialized clinics for rehabilitation, either pulmonology rehabilitation or neurological rehabilitation. Working on them or post-VA ECMO, post-resuscitation. You need good hospitals cooperating with you because you have to get these patients out of your ICU. You won't have beds anymore. But yes, if they are patient, if you explain to them that it may take half a year, they will still improve. We call all our patients back after half a year. We sometimes see them years later on. In VV ECMO, generally, the lung recovers sufficiently so they are able to lead a normal life. They may have polyneuropathy and myopathy for up to 5 years, but my experience is even up to 5 years, polyneuropathy still can improve. So a lot of patients, a lot of working with the patient. Don't give up.
Wow, fantastic. I mean, so rehabilitation can go as high as 5 years. It means, I mean, so we have to be that much speculative about, strategizing our strategies for rehabilitation. Dr. Urban, what is your experience? I've seen a lot of your patients, moving out of ICU, even on ECMO. I have seen one of your patients was standing with ECMO. So what is the strategy that you follow as far as rehabilitation is concerned?
Actually, the rehabilitation part is a new concept in India, and we don't previously we don't believe in rehabilitation. Patient going home, that's all. But after this ECMO thing, you are the main friend of that person. And many a time the stigma comes that he's ill, his colleagues tell he's ill, he can't go out, he cannot move around, he should be always under the mask, under the covering and all this. So a lot of psychological, lot of physical, what Dr. Muller told, the physical thing you have to take care of. And from the when the ECMO run is starting, and obviously to avoid all these things, sepsis, you are there. But most problematic time when he goes home, and that is the time you have to give a good amount of support. And it has become a personal level of interaction with a video calling, daily visit, or maybe some kind of psychological boosting. You'll understand, you can understand a few things, few small things can take his peace away. Like a lot of hair falls happen in the young females, they go on depression because of that. A lot of skin scaling happens. These are not limiting phenomena, but these are causing, they have scars of the tracheostomy, the cannula side, that that looks like disfigured of a 29-year-old mother who was on ECMO because of the pregnancy and came out and found that 2-3 spots are here. So aggressive counseling and things are important from very much personal side. Still in India, I don't know what happens abroad, but with my patients, I continue to support them till for the personal level, apart from the physical and physiotherapy exercises.
So it means you have a supportive team who will look after even if the patient is discharged, and follow up phone calls and video consultations will be a routine.
Yes.
Apart from your clinic.
I ask them to. I ask them to report me even if they are a bit ill for other reasons also, or they are not feeling well. They can call me. The time has been given for a 9 to 10 or 10 to 11. They can call me. They can WhatsApp me, because that is my extended family, and a lot of groups are there. If you found in the social medias from the different part of the world, if you add them, they can share their things and they come out well.
Dr. Nilesh, you would like to share your experience of rehabilitation?
So just like all other panelists mentioned, we believe in early mobilization, keeping the patients as awake as possible, and post decannulation, essentially with all the problems that they have, having a kind of a support group. We have a kind of a WhatsApp group which we form, and through which we try and communicate with each other through that. Physiotherapy, ongoing physiotherapy, good nutrition support, and psychological support essentially forms the crux of it. And trying to showing them light at the end of the tunnel, essentially, that they themselves value their life more, essentially, once they come out of this. And I've seen that their attitude towards life changes as well. They give importance more to things which really matter in life than sometimes being sucked into all the other things which we keep on going for, essentially. So I've seen a big change in their attitude as well once they survive this kind of like a near-death event, and can consider this to be like a second life for them. So it's more of a ongoing support for them with the help of a multidisciplinary team, and that is really appreciated by the patients.
So yeah. So, sir, before we wind up, just a very interesting question from my side, actually. Sir, I would like to ask every panelist, what is the longest ECMO, sir, in your centers? Like, sir, to Professor Muller, what is the longest duration of ECMO, sir, you have encountered in your center?
The longest was
Yeah.
196 days
Oh,
with weaning and
Great.
discharge.
great. Diwan, sir, what is your... Sir, you are mute, sir.
The longest is 64 days, obviously COVID. Ended up getting a lung transplant, airlifted to Chennai for a transplant, came back, stayed with us, now doing well and extremely hale and hearty.
Great.
Young guy, 38-year-old.
Great. Arpan, sir?
Surviving highest is 96 days. He's doing well now, COVID. Non-surviving is 141 days. The family didn't give consent for transplant. So rendered futile, and we have to say bye-bye to him. That's an ethical concern was there, but we have told that he's not improving.
Yeah. Dr. Nilesh?
45 days in Deenanath Mangeshkar, but did not survive. In Australia, we've gone up to 65 days and the patient survived without a lung transplant.
Yeah.
Wow, that's fantastic.
Dr. Subhadeep? Okay.
In our center, if you talk about the survival things, then the highest survival, one patient was on almost 31, 32 days. One lady was there for almost 89 days, but we could not make her, and the family was not given consent for the transplant and everything. That was in the COVID setting. Non-COVID setting, one lady was in almost 32 days after that she got survived.
Yeah. I have one question to Professor Thomas Muller. I know you are working on miniaturization of the ECMO devices. And, presently still the device is, though it is called as handy, but I think you are working on reducing the size and trying to, make it more simpler and easier. So can you throw some light on this aspect as well? I mean, so that the ECMO machines can also become more transportable, more handy, and more user friendly as well. So this question
cheap and cheap
And cheap.
and cheaper
cheap.
also. Yes. So this is a
That's a
very
big
interesting question that I would like to ask you also, and please all the panelists also please contribute your thought process pertaining to this innovative idea.
Yeah, I think one of the problem is there will be physical limits to what we can achieve. We need a certain blood flow. We have to, as I showed in the beginning, we have to transfer a certain amount of oxygen. And for that, you will need a certain size of your oxygenator. My feeling is the oxygenator we may not be able to decrease that much more. We probably will be able to improve pumps a little bit. We are, as you know, in CardioHelp is already, the pump is integrated into the oxygenator. And we will have devices which will carry, you can carry around and have less weight, probably just using a battery. But overall, I think concerning size and weight, we are close to the limits. That will be different when we do CO2 removal, but we are not sure whether CO2 removal in the long run is actually improving survival. But yes, for CO2 removal, you could work with smaller devices and could support your patient sufficiently. But I think in the near future, we may see slightly improved oxygenators, improved pumps, or slightly improved. Maybe we need less anticoagulation, as we all do already. We run our patients for 14 days without anticoagulation. But I think actually current devices are already quite good. Sorry, concerning pricing, they will not come down. It's considered to be rather cheap.
So
we have to make our own circuit, Akhilesh.
I have actually one query to Professor Muller and everybody in the panelist. from my side, just for an understanding. It's a non-medical question, but I just need to try to understand from my side. So what are the biggest challenge you all have faced to set up an ECMO center in your institution? So if you ask me, we are also facing, we are in the Apollo Mumbai, we are also facing a lots of challenges from the administration side.
We are really facing problems here. Yeah. So, but
it's-
nevertheless, we are still striving hard. Probably we will be able to get through.
Probably
Still,
all
we
of
would like
you,
to learn from your experience as
yeah,
well. Yeah.
yeah, can help us to develop our eCPR programs also. All the panelists. This is my sincere request.
Sandeep.
If you look at the Indian context, it's very different from the other part of the country. Okay. If are you specifically asking for eCPR challenge, or you're asking for an ECMO program challenges?
We can
For
talk about
ECMO program challenges first. eCPR comes later too. Yeah.
I think ECMO program challenges, the main challenge right now is the belief and the awareness among the community, and particularly among the doctors, that ECMO helps. The second challenge is and I can actually, so whether you take me on a drink, then maybe I can tell you 50 challenges, but I will tell you the major 5 ones. The major ones is the awareness. The second, I think, is the training.
A first challenge that we face is administrative challenge. How to convince the administration. That is also one of the biggest challenge that we have. Please highlight on that as well.
The second challenge is the training, because I don't think we create teams. Right now, I think most of the successful centers that you are seeing, you have teams. If you can look at Dr. Arpan, they have a good team. So it's not about an individual. It's about the whole team of critical care, cardiologists, pulmonologists, cardiac surgeons, perfusionists, physiotherapists, nutritionists. Everything has to be, and the administration, coming together to make a successful program. Now, third is obviously I would not say administration is a challenge, but yes, we are living in an era where we are into private healthcare. Unlike other parts of the world, like Thomas they have a public healthcare system. We are into a private healthcare, so anything that you demand from the administration, you have to really convince yourself that you'll be able to have enough number of patients to actually pay back whatever is the investment that goes into the development of the program. Administration will never say no to any program as long as you are convinced that it is clinically relevant and they are convinced that it will bring in more patients into the hospital. Sorry for my straight talking and prudent reply. So for your colleagues and your physician friends, you have to convince them that it helps clinically. To the administration, you have to tell, yes, it will increase the reputation of the institute. It will increase the footfall of the patients. And let's accept the reality. If 100 patients are referred to our ICU, only 30% will end up actually requiring ECMO. They may be referred for an ECMO, but most of them do well with proning and good strategies and everything. Am I right? So if you explain administration well that, look, it's a program which will not only bring ECMO patients, but it also bring in more respiratory or cardiac failure patients to the hospital, convincing them is not an issue. So that is the third challenge. I think the fourth challenge is, which is also pertinent, is I think Arpan and guys don't have it. Sorry, Arpan, because there's a clear demarcation between critical care and cardiac anesthesia running ECMOs. So Thomas faces that challenge. The perfusionists are loyal to our cardiac surgeon and cardiac anesthesia colleagues. So first 2-3 years, we faced a lot of challenge when we tried to convince the administration and the surgeons and the anesthetists to please give a perfusionist who can actually align for the active program, but this was a challenge. But as you will grow in your numbers, these problems will get sorted out. See, everything, if you are able to increase your ECMO runs in more patients, if you are given to give more survivals, your ECMO program becomes a success in the span of few years, things will fall into place. So I think now we don't have those problems because we have a big team of perfusionists. All of them are trained in ECMO, and it's written in their KRA that their appraisal is done by both Director of Critical Care and Director of Cardiothoracic Surgery. So we have reached that level of discussion with the surgeons and the administration that, see, why will a perfusionist do it? Please understand, because their loyalty is towards the OT, and they have to run an OT at 8 a.m. and you will call him at 2 a.m. So he will also say, what the hell are you calling me at 8? I can't say no for an OT at 8 o'clock. So I think you will have to be very, very friendly with your cardiac surgeons and cardiac anesthesia colleagues to convince them to send the perfusionist 24/7. We do retrievals, and the retrievals can come anytime. So I think that's where it was a challenge for us. Now it's no more a challenge. I think cost is a big factor in India. We lose a lot of patients early because of we have to switch off ECMOs. Ethical, non-ethical, I don't know, but we have to switch off for cost reasons a lot. That's a big challenge in India. We go for a portable ECMO. The circuit costs 3.5 lakhs. So that's a huge cost on the first day. I think cost is an issue. If we decrease the cost somehow, the number of ECMOs will again grow. Now the rest can be long, Dr. Subhadeep, but I think these are the 5-6 major challenges which one needs to actually nursing. You can't undermine creating a set of ECMO trained nursing. We have 16 now, but you can't. It is very painful. You train them, they go out. Train them, they go out. I'm sure all of you suffer the same problem. So we again train them. So one of our consultant, poor guy, is only training nurses because we need the nurses. Then they go and they all take certificates from you and they go to Dubai and Thomas. They go to Germany also now. So
you're welcome.
The nurses are a big challenge.
So how frequently do you run the training program?
Sorry?
How frequently do you run the training program? It's a kind of continuous process, or
no, it's also program. We started this course pre-COVID, and during COVID we had converted into online the theoretical. Now the next one we do it every 3 months. So the next one is coming in the end of July. It's a 4-day physical program at Fortis Gurgaon. So every 3 to 4 months we are allowed to take 20 candidates. So that's how the program is run. So every 4th month we do this program.
And it's a comprehensive 4-day course,
Yeah,
basically, and with the hands-on training.
Yeah.
Can,
yes.
yeah.
So you actually do cannulation. You put the patients on ECMO. On the mannequins, we have simulations. Like I told, hybrid ECMO is one of the simulation. People are afraid of taking patients to CT scan on ECMOs. That's one of the simulation. I think I'll call Arpan for how do you prone on ECMO. Maybe create a simulation scenario on that. So the students really enjoy it, and they become confident once they go through that.
I would like to know from Dr. Nilesh as to how he has started setting up ECMO at his place. And he is also working on eCPR. Can you highlight 2 ideas that you have?
I mean, first of all, I think Dr. Sandeep exhaustively jotted down all the points which add problems which all the new centers encounter. For me, essentially, I was coming from a place where, you talk about ECMO and everything is kept ready for you in Australia, where the nurses and everything is so well trained. And coming over here, I remember my first 5 ECMO cases which I did, I was living in the hospital for at least 48 hours. I did not go home. Because, you can't, assume nothing, believe no one kind of a philosophy in which people were not trained, and then we started off in a situation in which only few nurses were trained, and none of the doctors, very few doctors knew about it. So I think it's a very painful situation to go initially, but I think later on, as Dr. Sandeep mentioned, with ongoing training, like we conduct courses twice a year, and we've got around 10 nurses which are ECMO trained. We do also have the problem of attrition, so we just have to keep on training them. So I think it's just the ongoing, one has to be really passionate about it, first of all, and don't look at the gains that you're going to get out of it. I think being more patient-centric than being ego-centric, working as a team and being a team player is something which definitely helps in the long run. Because no single person can bring about a big difference. You require a fabulous team where everyone has got a say, who can, speak out, essentially will help you in the long run. So, and you have to invest yourself and your time in your nurses. You have to invest your time and resources into having a good perfusionist. I think that will take your program a long way ahead.
And what is your message for this eCPR? How to run a successful
eCPR, I would say, is always an icing on the cake. Your cake has to be good enough. So I think one has to be good enough with the elective VV and VA ECMO scenarios, as well as cannulation. And eCPR is something that one has to build up. It's a commitment. One has to be available 24/7. So it's only when you think you are ready, your entire team is ready, something one should, subject yourself to that. I personally feel once you are confident enough with your VV and VA runs, one should venture into eCPR. That is my take on it. I would be happy to be guided by the other panelists.
Can I add something? Can I add something?
Yes, sir. Yes, sir.
We did 6 cases of eCPR. Unfortunately, 2 we could not cannulate because of the it's not easy to cannulate in a cardiopulmonary resuscitation. We called the surgeons. The problem that we faced massively in eCPR is that how do you talk to the family about a consent? eCPR is not standard of care, you understand. Now, a cardiopulmonary resuscitation after 20 minutes, if you want to go to eCPR, here in India, you have to talk to the family. Okay, and I cannot have a protocol in Fortis that 20 minutes of CPR, young guy, most likely cardiac origin of cardiac resuscitation, go to eCPR. That's not a protocol that we have. So unfortunately, we waste a lot of time talking to the family. One consultant is talking, and the problem is you're opening a 2.5, 2.7 lakh cannula just on an assumption that you will be able to cannulate and you'll be able to give a survival. I'm not going into the neurological aspect right now. So we've done 6, but the problem is we burnt our hands because a lot of time they ended up with discounts. A lot of time the families did not pay. So that's a challenge which you must keep in mind. See, India works very differently from say Australia or Europe or other areas where it's public system. So the families plain said that, see, he had a cardiac arrest, you tried your best, that's it. So a lot of discounts came under the name of Dr. Sandeep Diwan. So after now we are trying to make a protocol in Fortis that either for an eCPR, a young patient eCPR, we will not talk to the family about the finances. If the patient does not make it, then it has to be waived off by the organization where we are not finding support. So right now we are actually kind of refraining ourselves from doing eCPRs even in hospital cardiac arrest. Out of hospital for us is out of question right now.
It has to become economical.
Yes.
All the circuits and everything. Well, the machine charges and the other charges can be waived off. Only the circuit charges, if you can just add on to the expenses, probably that would also do actually.
Sir, Professor Muller, I would like to know from you how do one basically recognize as a center of ELSO certification, or what are the criteria that the center need to fulfill for the ELSO certification if you want to certify the center as ELSO recognized institute?
Depends which level you want to achieve. If you want to have to achieve a high level, it is a lot of work and you have to be very good. Becoming a member of ELSO is not that difficult. Yeah, you just have to tell them you want to become a member and actually place your cases into the registry. Then you can easily become a member. If you want to be certified, there is actually quite a path you have to fulfill to be recognized finally. We do it every 3 years. It's actually my part to do it. Costs me several days of my life each time. I think in principle, many challenges which were just mentioned, Sandeep, you very well did mention everything which is important. I think when you were able to fulfill all these requirements, when you are a team, when you do proper training, when you have your staff trained, when you have a good teamwork, when you have networking with other hospitals, I think also important is, as was said, that you start with VV because it's the most simple. Then you go to VA Thereafter, you may start transport and ECPR at the very end because it's the most difficult. I also think if you want to do VV, you should be actually an ARDS center. So only ICUs which are very experienced and have all options for treatment of severe lung failure should do VV ECMO. The same is true for VA, only those who are actually cardiac arrest centers and have all options you need for severe cardiac arrest should go for VA ECMO. You may do it in a smaller hospital, but then you have to cooperate very close with a center which is nearby. So fulfilling all these requirements, and if you have the feeling your center is running well and your outcome is comparable and all your procedures, you have your standards, then I think it's time to become a center of excellence from ELSO. But they are quite strict. The process is not easy.
Yeah. For that, we have to be a high volume center and we should have shown results as far as the ECMO success is concerned. And we should have a trained team, a comprehensive team who is looking after the ECMO services. And probably if you have good volume, then only you can apply for registration and can get recognized. You should also have training and education in place as far as the center's recognition is concerned, probably.
That's true, yeah. Of course, with a higher volume of cases, your quality will improve and you will have constant training with the patients already. Everybody has to be enthusiastic. All your team, your nurses, your perfusionists, and of course your administration have to be enthusiastic if you want to become an ECMO center. It's really teamwork, as everybody said. If it doesn't work, if you don't have the team, don't start it.
Yeah. Okay. So there are no questions. I think the chat box is empty at the moment, and we are at the end of this session. It's time to thank you all. I mean, I must thank Dr. Professor Muller. You spent your time, and really it was worth having you with us, and you really enlightened all of us with the topic. And we would like to hear from you again and again. And hope to see you again. I mean, I would be overwhelmed if you can accept my invitation and again. I mean, I will be really overwhelmed. Thank you for today's presence and really love to hear you. I would also like to thank Dr. Diwan. We've been talking about this since long, about ECMO Center, how to develop ECMO Center and all that, how to start training. But this time we are really serious about this, and hopefully some of our students will enroll for the also recognized training program that you are coming up with. When is the next program? Please do let us know, and we'll see that some of the students, and we also may register for this training program.
We'll send you the brochure. Dr. Manish is here and Dr. Madhur will send you.
Oh, sure. And I also thank Dr. Arpan Chakravarti for sharing your views on different aspects of ECMO, and really overwhelmed. And you have really made a difference as far as ECMO success is concerned. Actually, I have heard a lot about you from the social media also, and a lot of people have admired your achievements. And you would like to say something? You raised your hand.
Yeah, just a tribute to Dr. Muller, because Dr. Muller and Dr. Diwan did a very good webinar on acute pancreatitis on ECMO. And I was there actually to hear about this thing, because my previous 2 pancreatitis patient on ECMO died. I could not run one ECMO for 24 hours and another died on day 7. Pancreatitis is a very bad indication to put on ECMO. So I stopped putting patients on pancreatitis. For the last patient I retrieved a patient of pancreatitis. He went home day before yesterday after 45 days. So I'm thankful to them, Dr. Diwan and Dr. Muller, just enlightening on that, because there are indications which are extremely good for India, like dengue, like pancreatitis, like sepsis, which are very much available in your ICU, and we have not been able to solve the puzzle how to get the ECMO in it. All the contraindications are getting the indications of ECMO now. So probably the way ahead.
Dr. Arpan, we were third time lucky. You are also third time lucky.
Yes, yes. So we got it out.
And
Thank
I also would like to thank Nilesh, Dr. Nilesh, friend of mine. Really love to hear from you today and hope to see you again and again. And I hope your ECPR program that you are trying to run would have a great success ahead. My best wishes to you as well.
Thanks, Akhilesh, for having
Thank
me.
you
And
very
I
much.
would personally like to thank all the senior panelists like Dr. Thomas Miller, who's essentially an inspiration globally for everyone. And, the inspiration for people in India essentially are Dr. Sandeep Divine and Arpan Chakravarti. So thank you for your input as well. I always learn something, always talking and being, listening to them essentially. So thanks for having me, Akhilesh. Thank you very much.
Oh, I know Professor Muller, India is the second home for him. People call it like it's the second home for him. Okay. Yeah. And I would also like to thank Dr. Munish Chavan. I mean, he has been, pushing us a lot for ECMOs at our place also. I mean, he has inspired us a lot on many occasions. And we had an opportunity to have him with us for one ECMO program that we did it, and hope to see such more programs again happening at our place also at Apollo. We would like to conduct more such programs, and though it may not be also certified, but at least some sort of simulation based and workshops can be arranged. I would definitely need your help, Dr. Munish, for this.
Definitely,
And
Dr.
thank you for
Akhilesh.
coming.
I'll look forward to this. Sorry, I was on regular calls in the ICU, so wasn't able to participate much.
No, we can
Especially
understand
there.
this.
But
Yeah,
I would really look forward to meet you.
Yeah, hope to see you conducting ECMO workshops. Divan sir, I will need your help also. And Dr. Chakravarti and Dr. Nilesh, I mean, would really love to have such programs. Now the COVID is over, probably we can have workshops and simulation programs at our place also. And I would like to hear from you all also a small message that you would like to deliver it to all the delegates that are there, starting from Professor Muller to all the panelists. A small message regarding ECMO that you would like to deliver it to all the students.
A small message. I might start because you're somehow right. India became second home for me thanks to Sandeep. Because he always invited me, and I don't know, Sandeep, you remember when we went to Amritsar? I took a small seed of a tree. It was very hot when we were there. We were at the Golden Temple, and then we actually were walking around, and I took a small seed from a tree, an Indian tree, which I planted here in Germany, in Regensburg, and it's almost 2 meters high by now. So
I thought it will grow in Germany, Thomas.
It does because of the climate change.
So can we send our student to your institute, sir? For any time for the either observership or for any fellowship programs to Germany.
And what would be the pathway for sending people to your centers?
Yeah, there's a problem.
I know Dr. Divan Center is all open for us, but people would be curious about your center as well.
No, Dr. Akhilesh, there's no comparison. There's no comparison between a teacher and a pupil.
It's nothing I can teach anymore. Sandeep, it's not true. You are teaching now as well. So I'm listener as well as somebody who is lecturing. I think it's mutual by now because you have your experiences, you have different experience, and we learn from each other.
So when is the next program in your institute, sir?
The next program actually is in September, but it's already booked out.
So we have period.
Yeah, we have it's always rapidly booked out. Once a year we do a 5-day course, and that's always rapidly booked out.
And how about sending people as an observer to your center? What is the pathway for that? How do we get in touch? Any pathway for that?
I have to clear with my administration a real postgraduate program we don't have. So it is more like coming for 1 or 2 weeks and seeing what we do.
Yeah. So for that, I mean, just to let us know, I mean, how we can facilitate that as well, so that we can also have some academic exchange. Most of our students would also be keen to learn ECMO from the higher centers like your centers, and they would also like to have the exposure from the Western side as well. So I think the protocols may not differ, but your experiences would be really of great help to them as well to have a standardized approach as far as management of ECMO is concerned.
Yeah.
So please let us know about the pathway as well.
But all
So
my knowledge is already in Gorgon.
okay, yeah, it's already there. Sure. So with this, we would like to conclude the session, and I wholeheartedly thank you all, the speaker, the panelists, and I also thank my friend Dr. Gunadhar, who is my co-moderator. And this is how, I mean, we have built up this program over a period of time, and this is our 12th educational program that we have come up, and students have really liked it. And that has given us a motivation to have more and more such programs. Every week we have such programs, conducted with the eminent faculties and eminent panelists. And I hope there is a great learning from this educational program as well. And with this, I would like to conclude and thank you all, and good night for now. Bye bye, and see you again, and hope to see you again and again. So thank you very much.
Thank you.
Thank you, Dr. Muller.
Thank you.
Thank you.
All the best to everybody.
Thank you.
Thank you. Good night.
Good night.
Good night, sir. Good night. Good night. Good night, sir. Good night, sir. Good night.